Welcome, ladies and gentlemen. Good afternoon, good morning, good evening, wherever you are. You are logging into the Uganda Strengthening Supply Chain Systems Activity webinar, the fourth in the series. During this, we are going to share our experiences as partners who have been managing this activity and collaborating around this activity so that we get to appreciate what have been the experiences, the different partners who are members of this consortium, as well as the government partners who have been participating with us as part of the transition, part of the localization of the activity over the last almost 5 years now. We shall be expecting a lot of questions from your side and clarifications to the extent possible. And we'll also be happy to share, if you can share your own experiences wherever you are. Your questions, comments, please pass them through the chat. We have a co-host who is going to manage the questions or clarifications. And at a point in time, you will be getting responses, whether through the chat or later through some other forum. Basically, we shall be posting the information to the MSH Management Sciences for Health website, where all the participants of this particular webinar and others that have already taken place can find the recordings and additional information on the seminars, on the webinars. We have a number of speakers. As you can see before you, we have Dr. Eric Lukata, who is the Chief of Party for the USAID Strengthening Supply Chain System activity here in Uganda. We have Martha Ajulong, Dr. Martha Ajulong, who is the Acting Commissioner, Health Services, responsible for the pharmaceutical subsector. We have Dr. Arthur Bainomugisha, who is the ED of one of our consortium members, ACCORD. We have Dr. Ms. Grace Salichwanuka, who is also the ED of the second member of the consortium, Uganda Health Care Federation. We have Mr. Boaz Musimenta, who is the Principal Policy Analyst in the Office of the Prime Minister. The OPM is the Coordinator of Government Business, and by default, their mandate is also to coordinate this particular activity. The detail will be presented by Mr. Boaz Musimenta. We have Dr. Kamaradi Mazembe, who is our Principal Inspector at the Ministry of Local Governments. He's going to speak to their role, responsibilities related to local government, district local government work, and specifically what their roles and responsibilities, their experiences have been in implementing this particular activity here in Uganda. And finally, we shall have Dr. Anna Lawino, who represents amongst a number of US-funded local implementing partners, the views, the experiences, and lessons learned at the level of service delivery. They are doing the last mile service delivery. We shall be hearing from her the experiences and the lessons they learned in doing so at that level. My name is Martin Oteba. I'm the Deputy Chief of Party of the Uganda USAID Strengthening Supply Chain Activity, a 5-year USAID supported program here in Uganda and being managed by Management Sciences for Health. Today, we are having the fourth in a series of our webinars. focusing today specifically at localization of health supply chain support in Uganda. And as I've been mentioning, the experiences by our partners, the partners in implementation of the strengthening supply chain system activity. Today, we are going to hear from those partners and specifically their experiences and lessons they've learned as we implement the activity here in Uganda. We have experiences around leadership, management, and governance of the health supply chain, as will be shared by the appropriate ministry, department, and organization, and agency. We have experiences and lessons learned around supply chain systems capacity strengthening, as will be shared by our partner in that field. And we shall also discuss experiences and lessons learned in the organization, coordination, and management, including oversight by the government through the 4.5 to 5 years that we've gone through working together with the government in strengthening the supply chain in the country. Finally, we are going to have a lessons, experience, and observations made by our partner, referred commonly here as the implementing partner, a USAID-funded last mile implementing partner, who will give us an experience of what has happened at the last mile and how we have been engaged. So today, we are joined by two prominent speakers who are going to kickstart us. And the first one is nobody other than Dr. Eric Lugada, who is the chief of party of this particular activity, USAID Uganda Strengthening Supply Chain Activity. Dr. Eric Lugada is a public health specialist, an epidemiologist. He's got long-term experience in managing projects like this one, and he has been, from the inauguration of this particular project, the chief of party for the last four and a half or so years, and we hope that we are going through up to the end. Dr. Eric, I will welcome you to give your remarks to the audience. I will remind every panelist that you have 5 minutes at most, so that we'll catch up with the assignment. Over to you, Dr. Eric.
Thank you, Martin. Good afternoon, good evening, and good morning, everyone. Welcome to this webinar. Today, we're going to be discussing how engaging local partners and the government has been throughout our journey. We are a strengthening supply chain activity that was contracted by USAID for a period of 5 years. We are in the process of reaching the last mile, and we had local partners we worked with, Advocates Coalition for Development and Environment and Uganda Health Federation. We've been working together to strengthen the national health supply chain systems in this country through enabling good governance, helping to institute supply chain measures and management systems so that they can function well. But at the same time, we're also charged with the responsibility of supporting the government to build the local ability and capacity to plan, finance, and implement solutions that can manage the challenges that the supply chain faces in the country. We are what they call an above-site mechanism. It means covering the entire country, supporting both national, subnational, and community entities. We had 3 result areas. The first one was to continue to improve through targeted improvement on existing supply chain national systems, which had been built to certain levels, but we added on to make sure that there's visibility of commodities, essential medicine and health facilities through the entire supply chain of the country. The third one was to provide technical assistance to the ministries, departments, and agencies of the country so that we can improve supply chain function and enable visibility of essential commodities throughout the supply chain system, from the warehouses to the patient, so that we can promote transparency and accountability. And the final one, it was hoped that by the end of the 5 years, we would have achieved transitioning of supply chain responsibility to the government of Uganda and local partners, including funding for these activities. So we adopted the USAID mantra, which is very specific. That's USAID had set out in their localization approach to promote local learning, where USAID promoted community and national engagement in learning, use of local resources so that we can scale up the utilization of resources from our country, including from the private sector, to support the entire system. They also leaned on promoting local systems that would help improve the programming so that it's designed locally and owned at the end of the day by the local entities in our country. And to that end, we supported the government of Uganda to put in place what we defined as a 10-year roadmap. And that 10-year roadmap was solely looking at localization. And we used the one government approach of the government of Uganda, which promotes interministerial collaboration of ministries which have a unified or a common action. In this case, there are many ministries which impact health, and it has 5 components. One is collaboration for unified action, which is to improve health services and avail commodities or health facilities. Through that unified action of the one government approach, also promote transparency and accountability to enable governance of resources that have been invested. They enhance capacity strengthening of technical staff within the ministries, departments, and agencies which work together. And they also work through an integrated approach which shares the resources and ensure that there's improved delivery of quality healthcare services. And finally, they incorporate a robust monitoring and evaluation mechanism, which we have supported the interministerial team to put together. There are about 8 ministries working together: Ministry of Local Government, Ministry of Health, Ministry of Public Service, Ministry of Information and Technology, Ministry of Energy, Ministry of Finance, to ensure that health commodities are both supplied and availed to the entire country and when they are needed. We hope that creating this 10-year roadmap, we should be able to strengthen local involvement, improve the efficiency of government, and create a resilient supply chain system that will enable and spur economic growth, but at the same time improve the health of the Ugandans that we support. Thank you. And with that, we've partnered with local partners. We're going to see how they've been able to benefit, and eventually we look at the ministries, how they've benefited from this engagement, as well as the local implementing partners within the country through whose capacity we have been able to build. Thank you.
Thank you very much, Dr. Eric. Ladies and gentlemen, localization is not just a simple buzzword today. It is a policy direction that USAID, MSH, CDC, and many other organizations involved, including the UN systems, are pushing in the development agenda. As Dr. Eric has just mentioned, we work with so many of those entities that relate to the health sector in trying to ensure that our activities don't slip off as soon as the project is concluded, but rather it is sustained. So in a short phrase, localization is also a sustainability approach to ensuring that all activities that any development agency is supporting right now continues once the project in question is closed. Our next speaker is supposed to be Dr. Martha Ajolong, who is traveling, is somewhere in the Far East. It seems like she's just failed to join right now. I think we shall skip her. In case she comes in, then we shall move ahead to invite her to say something to us. But otherwise, she was representing the Ministry of Health, the department with which we engage as an activity in strengthening the health supply chain in this country. She is the principal, the lead of the department that is key in what we do. So I would take advantage of this time to introduce to you our panelists who are going to share with us their experiences. They will introduce their own organizations and the specific roles and responsibilities they play around strengthening supply chain in this country. So I'll take this advantage to invite you, Dr. Arthur Bainomugisha, to share with us your experiences, your lessons you've learned during the implementation of this activity, and if possible, any recommendations that you may have moving forward. Over to you, Dr. Arthur.
Thank you very much, Dr. Martin Oteba, and good afternoon, good morning, ladies and gentlemen. Already introduced as Dr. Bainomugisha Arthur. I'm the Executive Director of ACCORD, and ACCORD Infuse Advocates Coalition for Development and Environment, we're a public policy research think tank based in Uganda, but working in Eastern and Southern Africa. And our niche is to do public policy research and influence policy making, policy implementation, and policy evaluation. So we were privileged to partner with the MSH and the UHF to implement this activity. And through the 5 years now, coming 5 years, we've learned. We've had experiences, we've learned lessons, and we'll make recommendations to that effect. So, ladies and gentlemen, one of the lessons learned was structured capacity strengthening interventions that are driven by partners. We've realized that these structured capacity building, capacity strengthening interventions are very paramount for any successful implementation. And actually, because of that, we were able to achieve a number of things. Because of the structured capacity strengthening, Accord was able to benefit in a number of ways, strengthened by MSH, cybersecurity, training that we got, risk management, resource mobilization, fraud prevention and management, all those, and especially the OSCAR tool that was implemented, that was carried out and implemented by Accord, has not left Accord the same as when we started working with MSH. But secondly, we've learned that structured performance assessment tool like OSCAR is very vital for institutional capacity building, because when we assessed a number of institutional weaknesses were identified, and we started on a journey to build that, and actually fraud prevention, resource mobilization, cybersecurity, all those were interventions based on the OSCAR assessment. But we've also learned, ladies and gentlemen, that leadership and governance interventions are very critical in enhancing stewardship, ownership, oversight, and continuity of development outcomes. This is an area that Accord led on governance, and through this we are able to achieve to record a number of achievements. For example, the health supply chain strategic policy documents that were developed and disseminated. We also were able to train over 1,000 district and hospital leaders, whom we trained and mentored over time. But also learned that actually enhanced mobilization of domestic resources for health supply chain that we are able to achieve. For example, we are able to influence the Ministry of Finance, Planning and Economic Development to increase allocation for EMHS, which increased from 405 billion during the financial year 2020-2021 to 699.3 billion during the financial year 2024-2025. So we've seen that our work with Ministry of Finance, of course, as a consortium, has been able to influence government to increase financing for essential medicines. But we've also seen district budgets for the supply chain increased from Uganda shillings 179 million during the financial year 2021-2022 to 1.8 billion during the financial year 2024-2025. That is not really a mean achievement. But we've also seen that actually one of the experiences and we have learned lessons is that collaboration and partnerships are very, very important because we bring the synergies. In terms of lessons learned, we've also learned that structured capacity strengthening interventions, those were experiences, and the lessons is that structured capacity strengthening interventions driven by partners are very paramount for successful implementation of the programs. Secondly, structured performance of these tools that I've talked about is very vital for institutional capacity development. And moving forward, we recommend continuous capacity strengthening for local partners and continuous integration of leadership and governance interventions in the development programs. Thank you very much.
Thank you very much, Dr. Arthur. Colleagues, you've just heard from one of our partners whose sole objective within the strengthening supply chain system activity in Uganda was to handle the domain of leadership, management, and governance. We've now been joined by Dr. Martha Julong, whom I mentioned earlier, is the head of department for the Department of Pharmaceuticals and Natural Medicines at the Ministry of Health. You are welcome, Dr. Martha. She's on duty travel, and we shall give you 5 minutes to give us a quick statement around your experiences as Minister of Health. 5 minutes. Thank you.
Thank you, Dr. Martin and the MSH team. In the series on localization of health supply chain support through local partners, the Ministry of Health, Department of Pharmaceuticals and Natural Medicines embraces this approach to strengthening and transforming supply chain support to local partners. As the best practice, along with the MSH, arranged bi-monthly supply chain webinars, the Department of Pharmaceuticals and Natural Medicines has been keen to having an annual supply chain week with a lot of activities, including a supply chain scientific symposium. We also take note that, just to remind you, the Minister of Health, Department of Pharmaceuticals and Natural Medicines, is responsible for implementation of the National Medicines Policy to ensure that there is access to safe, effective, quality, and affordable essential medicines and health supplies for all as a central government for the universal health coverage. We have also taken note that there is sustained and effective supply chain and pharmaceutical systems capacity at the central piece, as a central piece in the achievement and sustainability of availability and access to health commodities. Historically, the health sector has gone through several transformations of technical assistance, largely from one international partner to another, with a capacity strengthening of our COD, UHF, and several other partners, local partners, like the Baylor, MJAP, JCRC, ANECA, TASO, and many others, local partners now that have significant capacity to effectively support supply chain interventions. The government of Uganda and Ministry of Health have a broader strategic framework fully aligned with localization agenda for capacity strengthening. This includes National Development Plan 3, which is now NDP, which is going to transform to NDP 4, and associated policies like the Build Uganda by Uganda, BUBU, to provide a foundation for localization at national level. The 10-year health supply chain roadmap that is well aligned to the NDP 3 and the new NDP 4, the Ministry of Health National Pharmaceutical Services Strategic Plan. The Ministry of Health coordinates stakeholders' efforts in strengthening health supply chain functionality at levels and is supported by various partners, both international and local, at national and subnational levels. Our partners like MSH have been very helpful in strengthening capacity and transforming skills to government ministries, departments, and agencies to sustain local capacity development. A key localization initiative championed by the Department of Pharmaceuticals and Natural Medicines with support from MSH has been the regional supply chain technical working groups that have been established in all the 22 regional and regional referral hospitals and are championing local supply chain oversight and technical assistance by the regional pharmacists. In other words, the regional pharmacists are the chairs of these regional technical working groups because we do not want as the project comes to an end, it ends with the regional technical working groups. So the pharmacists, the regional pharmacists are the ones to continue with these regional technical working groups. The Ministry of Health now intends to scale up localization initiatives to further strengthening the entire national health supply chain systems. Thank you very much, and I look forward to the fruitful deliberations in this webinar.
Thank you very much, Dr. Martha Jolong. You were spot on with the time, just as the predecessors have been. We've heard from the host, and now we get back to our consortium partner, Uganda Health Care Federation, who has been basically focusing, who has been focusing its efforts in capacity strengthening. I will invite the Executive Director, Madam Grace Salichiwanuka, to run us through their experiences, lessons learned, and if there are any recommendations around capacity strengthening and the development of tools that sustain capacity strengthening for the health supply chain. Over to you, Madam Grace.
Thank you, Dr. Oteba. I'll stand on the protocol already established. Good morning, good afternoon, and good evening to everybody. Uganda Healthcare Federation, the organization with which I work, is an umbrella body for the private health sector. And what makes it unique in its role in this project was that while we're an umbrella body for the private health sector, our work was to work with the public facilities at all levels, from the national and regional referrals right down to the health center FORS, to basically apply what we had found effective and helpful in improving quality in the private sector and apply that in these government facilities. When we look at our experience in terms of strengthening capacity of UHF through this project, there was really a unique 360 approach from MSH. We kicked off with an OSCA assessment, just like a code, both internally and externally. They availed an external consultant who came and visited and showed us how to go about one and encouraged us to do them repeatedly throughout the journey that we've been implementing this project. This has allowed us to refine our operations and fill our gaps and go from strength to strength, really transforming our organization. And this was supplemented with training for our board of directors to build their capacity to look at the organization from a sustainable point of view, as well as we received team building training with our team to improve our skills in terms of business, finance, risk management, and procurement. And then lastly, we also received some equipment and furniture that was really lacking in our organization. So as we grew, we were able to grow into our skin, and this strengthened not only our operations, but allowed us to expand the service offering to our members through webinars and CMEs that we now partner with national referral hospitals to offer a wider range of clientele across the country. We were also given the opportunity to be front-loaded with USAID funds. This is the first time this was done. And so we've had the experience of managing partner funding and being able to account for it rather than working on a reimbursement basis. And MSH has been really helpful in helping review concept notes that we've come up with to strengthen our project proposals. They've co-written proposals with us to enable us to improve our ability to attract funding So not only did they dress us as an organization and build the capacity of our staff, they also allowed us to be able to reach out and throw our net a bit wider. This has resulted in the development of the Digital Supply Chain Performance Assessment, which is an innovation that mirrors a tool that we had developed for the private sector. We've also developed the PPPH strategy document in partnership with the Ministry of Health. And we've also developed a supply chain e-learning module set that allows us to not only support government supply chain and logistics personnel to improve their work through them doing an assessment and taking these e-learning modules and then testing themselves and continuing to perform better. We've also initiated 361 health facilities to perform these self-assessments on how they're managing supply chain, with 82% of them scoring over 85%. We have also worked with 612 personnel in supply chain and enrolled them to complete a health supply chain management e-learning course. And all of this has been done through the support and collaboration with MSH and various implementing partners across the country. The lessons we have learned is that partnership is key, and not just in terms of the rhetoric of the term partnership, but it has to be real. And that partnership drives not only sustainability of the interventions, but the mutual respect that comes out of that partnerships embeds those solutions that you co-create to be intrinsic and become part and parcel of the health system. We've also learned that we need to look at structured performance assessment tools to drive effective collaboration and learning, and make sure we keep adapting to the environment. We've implemented this project through COVID, through Ebola, and right now we're tailing off during MPOX, and this has really shown the robust nature of the relationship and the partnership we have with not only MSH, but ACODE, who as a three-way party, we have managed to do a lot that we can't really go into detail in this webinar. So as we continue to build on this experience, the recommendations that I can maybe state that wouldn't be repeating what Dr. Arthur really ably articulated is that to really leverage the learnings from this localization approach. This unique approach that MSH has used, we've implemented many projects, but this has been unique in an approach from MSH, and it has allowed us to uniquely mirror what's working in the private sector and successfully apply it in the government facilities. And similarly, we've learned a lot as the private sector from government facilities that we are now applying through other interventions, through other funders in the private sector. And with that, I thank you, and back to you, Chair.
Thank you very much, Madam Grace Alichwanuka, for that very clear and elaborate sharing. In all that we do as partners, the government is the central organ that not only allows us to do that, but also ensures that we do it in the interest of the people of Uganda. We have walked the journey of the supply chain strengthening together with a number of ministries, departments, and agencies, including other non-government partners, as we've just had. And amidst them, in form of the coordinating agency, is the Office of the Prime Minister. We have with us the Principal Policy Analyst at the Office of the Prime Minister, Mr. Boaz Musimenta, who has walked this journey with us for a while. Mr. Boaz, can you share with the audience your experiences, lessons you've learned, and if there are any recommendations that you would make to make the future similar undertakings a success or even better? Over to you, Mr. Musimenta.
Thank you, Chair. Office of the Prime Minister has largely done its what is in line with its mandate, which is coordinating business, and under the coordination of MDAs, we have had frameworks and platforms like the Interministerial Task Force, which is actually a driver of what is taking place under the health supply chain management. We have also involved ministries, departments, and agencies to adequately plan for every financial year and prioritize interventions and allocate resources to implement those prioritized activities. We have also done monitoring and evaluation, and which is an area which is still evolving, which we hope we shall stabilize as we move forward. Mobilization of domestic resources, because the Interministerial Task Force actually does mobilization, brings stakeholders together and agree on what the priorities are, and then through that we ask government to improve in terms of the financing that we have had. Because of that, because of what has happened through those engagements, a number of lessons have been learned. One of them is that use of one government approach in strengthening the supply chain yields desired results. There are milestones after the 3 years, a number of health facilities connected. So we expect, we see we are moving really, and then efficiencies, of course, we have seen them. After the 3 years, we are seeing efficiency. Another lesson is that the common monitoring and evaluation framework for all MDAs eases performance management. And you see in government, performance management has been a thorn over time. And we have seen that when you have a robust M&E framework, you easily measure performance in real time. I recommend that given what we have learned in this journey, I recommend that we leverage the Interministerial Task Force for wider health sector domestic resource mobilization. It has actually worked, and we think this one will improve a further collaboration between stakeholders. And I also recommend that we continue strengthening capacity of ministries, departments, and agencies to utilize the one government approach. And that we have seen it works based on the results we have seen after 3 years of implementation of the 10-year roadmap. This is a modality that actually works using the one government approach. I thank you, Dr. Teba, and back to you, Chair.
Thank you very much, Mr. Musumenta. Without coordination, there is no head. So you've demonstrated the existence of a very strong head that then helps deliver results as expected. One other government agency that has been deeply involved in the implementation of the supply chain strengthening interventions has been the ministry, the Central Ministry of Local Governments. Uganda is very decentralized. We have 146 local entities, all of which are supervised, overseen, and directed by the Central Ministry of Local Governments as the key player. We have with us Dr. Kamaradi Mazembe, who is also in the field. We hope he's hearing us well, but he commits, because he's a committed gentleman, he's committed to delivering to us the message of their experience, lessons learned, and whatever the recommendations they may have after the 4.5, 5 years that we've worked together. Dr. Mazembe, over to you.
Thank you very much, Dr. Martin. Like you said, it's been a 4 or 5 year journey, which has been good and quite engaging. Like you indicated, we come to this engagement by courtesy of our mandate, which speaks to advocacy and oversight over the district local governments. Our experiences in that regard have been capacity strengthening for the district's leadership and governance. And this speaks to the technical teams that are headed by the chief administrative officers, as well as the political teams that are headed by the district chairpersons. This training has focused on what they ought to do by way of oversight and mandates, and has been quite useful. It has also involved enhancing supply chain supervision. You realize that whenever we've had these trainings, we've had the chance to look at the districts as well as municipalities and all lower local governments to see how well they are ready for this roadmap and what they're supposed to do and how they're supposed to do it. Another experience has been the mobilization of resources for the DLGs, as well as Ministry of Local Government. And this has evolved around incorporating health supply chain activities in the annual work plans and budgets. So it's now part of what the DLGs are supposed to do, and funds will be allocated to them based on that incorporation. So on those experiences, what have we learned? The first lesson that we learned is that integration of health supply chain activities into the Ministry of Local Government inspection tool is quite critical. We are mandated to do quarterly monitoring in the various local governments, but when we were brought on board by virtue of the 10-year roadmap, we incorporated health supply chain activities in the quarterly inspection tool. So when we go out to the field, we also look out for what the DLGs are supposed to do in that regard. The other lesson is the buy-in of the district local government leadership to enhance performance and resource mobilization. You realize that the political arm passes the various budgets of these district local governments. So without them being involved and getting to know what is involved in the budgeting process, it will be in vain. But the lesson has been that their involvement has been quite critical, because we realize now they pass budgets from points of knowledge. What do we recommend, given the lessons learned and experiences? We should have health supply chain performance integrated in the local government and leadership discussions, just like we've indicated. It's an ongoing process, and the appreciation is there for the various players in the local government chain. We also advocate for funding for routine supervision and oversight should be given priority. We have these quarterly inspection checklists, but funds at times do not allow us to do the inspection of all the local governments. So the recommendation is that we should give it priority and provide funds and resources available for us to do the routine quarterly monitoring. Then the last recommendation is regular and routine capacity building sessions for political as well as technical leadership. You realize that we have elections quite often, so new people come on board. We have political appointments for RDCs, and they are quite in number that are new. And also there's retrenchment and retirement, or probably dismiss, whatever the case may be. So all these new players need to be brought on board so that we are at par in realizing the benefits from the 10-year roadmap. That is all I have to share for now, but thank you, Dr. Martin, for this opportunity, and I look forward to a fruitful discussion.
Thank you very much, Dr. Kamaradi. That was very insightful and encouraging. For our listeners, RDC stands for the Resident District Commissioner. These are representatives of the President's office at the district level. They are the arm that watches what the local government does on behalf of the President. What we do at central level, whether it's a ministry, a development partner, or an agency like ours, MSH, in implementing the supply chain strengthening activity, would not yield any results without the last touch, the touch that connects what we do at the central and middle level to the final recipient of care, that's the patient. In that regard, we being an above site, according to our activity, we are expected to work through, as was mentioned by the chief of party, to work through other partners. And so over the last 4 to 5 years, we've been engaging with a number of implementing partners, USG funded, and some of them non-USG funded, to implement the strengthening of supply chain activity. We have Dr. Anna Lawino, the chief of party of one of the local partner health services located in the northern part of Uganda, the Choli region, sharing with us today their experience, the lessons they've learned in working together in delivering services, particularly strengthening the capacity of the final provider at the lowest level possible at the districts, under the districts. I call upon Dr. Lawino to share her experience with the audience. Dr. Lawino.
Thank you very much, Dr. Martin. Good afternoon and good morning, everybody on the call. I do work for TASO, an organization that is implementing the USAID local partner health services actually activity, as mentioned. We do work and support the local governments within the Acholi sub-region, and these are 9 local government units, to be able to increase access, quality to HIV and TB services through the aspect of health system strengthening. And as we are a transition award from USAID since 2021, so we have really enjoyed the collaboration with MSH throughout this journey. I must say that as we work in this region, we do work with multiple partners. We work through the above side partners, MSH and also UHA. We have other local partners as well in the region, like the G2G Gulu Regional Referral Hospital. We have the LSDA that does support the private not-for-profit as well, and also the local governments and the health facilities that we do work with. Now, in light of sharing my experience about how we have supported last mile supply chain to the health facilities, I wanted just to give you a preamble of what we do in light of last mile delivery. We do support the health facilities to do procurement planning, and this is basically to help them use their allocated budgets to ensure that they use the commodity data and also the mobility data to be able to properly plan for the stock that they need in terms of the essential medicines, but also in terms of the health supplies. And in terms of commodity ordering, we do support them to be able to make the necessary orders that they need. And likewise, when they receive these orders, to be able to do the assessments to see that the order fulfillment rates are good. And in terms of commodity reporting, we do support the facilities to be able to report timely and accurately. And then in terms of digitalization, I must say, working with MSH, they've been able to support a number of our facilities in the region to have computers. So we've been able to support the scale up of digitalization such that we are able to use systems to be able to manage the supply chain. And then in terms of capacity building and also monitoring the improvement, we've been able to work with the different partners, including MSH, to ensure that we support the medicines management supervisors within the districts to conduct SPAS supervisions. And this we've seen, it has been able to help us really to address the practices of supply chain. And last but not least, in terms of utilization of supply chain data, we do perform with the support of technical assistance from MSH. We do perform data analytics on a weekly basis, monthly basis, to be able to share dashboards that have performance for supply chain, which trigger implementation and response. And then in terms of sharing the experiences of what we've learned as a local partner, what I can say is that the local partner really needs adequate technical assistance support to build their capacity. And as LPHS Acholi, we have benefited a lot from MSH by having them right through the beginning provide to us that technical assistance support such that we are able to fulfill the roles of providing that TA for last mile delivery. And also having them in the region, I must say, despite them being an above site partner, they have co-located with us in Acholi to easily collaborate and share our experiences, share tools, have one-on-one mentorships, which has really worked out quite well for us. And then secondly, in terms of being able to have the different local partners within the region, there's need to be able to really harmonize and coordinate the different aspects. So we've leveraged on the Acholi Technical Working Group. I must thank the MSH team for spearheading the composition of this team, but also providing the framework for the Technical Working Group. The Technical Working Group is channeled and spearheaded by the Gulu Regional Referral Team. It meets on a monthly basis, collating all the regional partners, the district stakeholders, to be able to discuss really in light of supply chain, where we are able to hold each other accountable. And one of the lessons we can draw from this is that through this regular stakeholder engagement, we are able to foster really the transparency that we need to have, but also to reduce the duplication and be able to align ourselves to the national priorities that we need. Now, the other experience that I also wanted to share is in terms of the monitoring the continuous monitoring and quality improvement, where we use the MMSs to be able to conduct the routine SPARS assessments. This we've seen that it has helped us really to address the management of inventory. But what I wanted to highlight is that there's need to be able to invest in this structure through training, through mentorship, however, also through transport. What we've learned with the terrain of the region, when you do avail, for example, motorbikes to these people, they are able to move, and this is what we really need in terms of ensuring the resilience that we need for the system. And lastly, in terms of the data-driven decision-making, as I mentioned, we did have support from MSH to help us scale up utilization of data tools, for example, the RX solution. I must say this has really helped us to see that we have the facilities data very well. Thank you.
Thank you very much, Dr. Lawino. Ladies and gentlemen, you are logged on to the Uganda USA Strengthening Supply Chain Systems activity, and you've just heard from a number of partners who have been working together with MSH as a prime, and 2 local organizations as sub-awardees to the Strengthening Supply Chain activity. And along with them, you've just heard from the representative ministries of government, as well as the local implementing partner, who is a USG-funded partner. We have now concluded with the presentations. Thank you very much for listening. We have seen quite a number of questions come through, and we shall now, to the extent possible, since we have some little time, we shall now try to run through them. I'll ask some of my colleagues who have been looking at them closely to come on board. Dennis, do you have anything you've prepared to give, or hello?
Yes, thank you, Martin. There are a few questions in the chat. I'll just direct them to the prospective panelists. I'll read all of them, and then the panelists can come in one by one. So question 1 came in from Pamela Steele. Thank you for the question. It will go out to Dr. Eric, basically saying, as operations people, there is need for common understanding of localization. How do we define localization from an operations angle? And also, what exactly is being localized and what is not being localized? So I think that will go to Eric. Thank you, Pamela Steele. We are honored to have you on the call. We do know that you are a good champion of capacity strengthening through quite a number of your works. Second question will go to Dr. Martha Ajulong. Question comes in from Manuli Balibuza. It's more or less a comment. At the level of the central government, we have seen the impact of the increase in budgetary allocation for essential medicines and health supplies. Coupled with the digitalization of commodity management, we can only expect better availability and accessibility to commodities in public health facilities. So it's a comment. Martha, you will probably add to that. To Dr. Arthur, there is a comment around the OSCAR assessment. The question came in from Benjamin Kocho. Thank you, Benjamin. The question is, what is the OSCAR assessment? I think you need to clarify. And then from Mike Mugurani, thank you, Mike, for the question. He says, thank you, Accord, for the presentation and the visible achievements. Was the increase in the district supply chain budgets, including funds locally generated by the district, or only funds direct from the central government from MOFPED? MOFPED is the Ministry of Finance, Planning and Economic Development. So that's the 2 questions for Dr. Arthur. I think those are the questions. There's one for Dr. Anna that has just come through. Thank you for sharing about your work. I would love to hear more on what lessons you have learned from the use of the SPARS tool. How have you adapted it during implementation? That was the question from Annie Vetsan. Thank you, Annie. So, Dr. Martin, those are the questions. The panelists can respond to one by one. Thank you very much.
Thank you, Dennis. Dr. Arthur, you have more than one, so we'll give you the first shot.
Thank you very much, ladies and gentlemen who asked the question. What is OSCA? OSCA is Organizational Synthesis of Capacity Assessment Report, and basically this is a tool that is used to look at the capacity of the institution in a number of areas, including, of course, human resource issues, financial management issues, risk management issues. And the whole intention is that is to actually build your capacity. You assess, it is used to assess your capacity, and based on the findings, then actually there is capacity building. So when ACCORD was when this tool was, and want to appreciate MSH for the consultant who came, we were very free with the consultant, and some findings were established, and then working with MSH, we embarked on the building capacity, addressing the findings, including those areas where our capacity was actually built in terms of cybersecurity. You know, these days, cybersecurity is the thing. And so we built our capacity was built, enhanced. Then, of course, issue of financial management. Our team, our finance team was equipped, including the new tools for managing financial resources. Risk management were trained in how to. Actually, we even developed a policy. Were assisted from that training. We developed a policy on risk management. And so I would actually recommend it even to other organizations that they undergo that OSCA assessment, because at the end of the day, your capacity is built and enhanced, and you can qualify actually to get even money directly from USAID rather than being a sub-awardee. And that's what ACCORD is working on, and I imagine our colleagues at EHF. Thank you.
Thank you, Dr. Arthur. Mike Baribuza, I could chip in for the resources, whether these resources were only central government or also included local governments. As you know, the funding, whether at local level or central level, comes from largely one source, the Consolidated Fund, which is managed by the Ministry of Finance, Planning and Economic Development. But we also know that at a district level, from the taxes raised, there is supposed to be a remnant proportion of funds that the district local government has discretion to allocate internally or locally. Through the 10-year roadmap, the government emphasizes efficiency, and this efficiency, it cuts across all the ministries and departments. Whereas the commodity budgets were direct subventions from Ministry of Finance to the national medical stores to increase the amounts that go for procurement of commodities. The operational funding at the district level is a result of the rationalization by the districts themselves to allocate from the resources they get from the central government, and most likely, since there will be no division of the monies at the budget level in the districts, the local funding, the remnant tax revenue that they remain with, could also be contributing to what we see. But in short, we still need to continue to do advocacy to ensure that all the local governments use and look through the resources they have around available to them to be able to adequately prioritize for supply chain needs, whether it is operational needs or commodity needs at that level, since they have some resources that remain with them. That's what I have to say now. Back to you, Dennis. You had provided guidance. Maybe I will ask Dr. Eric to build on what just said to Mike.
Yeah, so thank you. Thank you, Martin. One question to me, I think the person asked what localization was. What do we mean by localization? I think USAID and most organizations, including MSH, have defined localization clearly. Localization simply means that we go to a country, for instance, and examine the existing system and infrastructure and work with the people, involve the people. In fact, MHS has been implementing the philosophy of Tao, which is a 3,500 year, which philosophy, which states that you go to the people, empower the people, help them to define what the problem is, use local systems to structure an approach for solving those challenges, work with them so that at the end when you leave, they will say, together we solved our problem. But at the end of the day, they will own the problem. Now, USAID has added to that localization, apart from the systems only, the implementation and the design should involve participation of local actors. For our level, it will mean all the line ministries involved, Ministry of Local Government, Ministry of Health, Ministry of Public Service, the Prime Minister's Office. We are all involved, for instance, in designing the decennial roadmap and defining what parameters will be measured, and even designing a monitoring and evaluation framework for this activity. That's localization, part of localization. We're working together as a government to increase. But critically also, we have to have leadership. The leadership of any localized system will be based within the local system itself. Like the 10-year roadmap is owned by the government of Uganda through the leadership of the Office of Prime Minister. This is an illustration of an example of local ownership. The Ministry of Health, Ministry of Local Government owns and manages the workers at the health facilities, so they take leadership. Ministry of Health takes leadership for the technical approach and it owns it. And then we have public service owning the hiring of people, Ministry of Energy providing power, Ministry of Information and Technology for providing internet, all through the leadership of the Office of the Prime Minister. And that's what we are referring to as ownership. And to crown it all, we are adopting the use of local resources. We've engaged the government to increase use of local Ugandan resources to fund. You've heard from Accord already, we've realized around 179 billion Uganda shillings in the last 2 years added to the purchase of health commodities from our country. That's using Ugandan resources. Of course, in addition to development partners. Currently, development partners are still funding 70% of our health commodity budget. The government is doing only 30%. The plan is to reverse that scenario. So by the time we finish 10 years, we hope the government will be using funding 70% and development partners will be funding 30%. That's what we are referring to as localization. And then finally, while we are implementing the program, we're employing an issue of learning, adapting, and being able to process the lessons learned, use them to expand and implement them elsewhere. So we are including a learning agenda so that ultimately at the end of the day, maybe in the next 30, 40 years, we'll have locally owned solutions, locally implemented programs, and fully locally funded entities by the government of Uganda. So that's how we're defining localization at a broader, wider perspective, global level. Thank you.
Thank you very much, Dr. Eric. I will now call upon Dr. Anna to respond to the question that was referred to you. We have a few more in the chat, which we shall address since we have time. Yes, Dr. Anna.
Yes, thank you. And thank you for the question. My question was in regards to the SPARS, what lessons have we learned implementing the SPARS tool, and also how we have adapted it in our program. What I must say is that with the SPARS implementation, what we have learned is that it integrates really the supervision together with the on-site hands-on training. And this is well efficient in terms of helping us to improve the capacity both for the health worker at the facility, but also for the medicines management supervisor that comes to conduct the SPARS assessment. And in a way, this we've seen it harness improvement across the different domains of the SPARS, as we've seen. We've seen improvement with stores management, with stock management, and also reporting and ordering. I can say at this point for the last almost 1 year in Acholi, we've had not less than 95% reporting in terms, for example, in terms of reporting for commodities. So it has indeed helped us to improve. And what we see is that capacity building, which is combined with the support supervision. And in terms of adapting it, what I can say is that what we have adapted in terms of utilizing it is in terms of customizing the dashboards for the SPARS to meet our needs. There are some areas that we've been able to add to it, such that we are able to really see across, besides not only the domains that are there, other things that we can be able to see to provide us input at the national, at a project level to be able to improve. So that's what I can say in regards to the SPARS. Thank you.
Thank you very much, Dr. Anna. There is a question in the chat which says, and to all presenters, you presented only positive lessons learned and experiences. Were there any negative experiences and lessons learned? Anyone who wants to give a shot among the partners?
Yes, I could share on that. Unfortunately, I think the time cut me short in regards to sharing one of the lessons, perhaps that was negative. I think for local partners to be able to fully support last mile delivery, there's need to be able to provide adequate resources, both in terms of human resource and finances. And what we saw earlier on in our projects, when we started, we didn't have a structure, first of all, for supply chain. And we had to quickly align some of the budgets elsewhere to see that we bring on board supply chain actors in the project. So I think as a recommendation, there is need really as local partners to have resources that are able to have both HR and finances to fully support the last mile supply chain technical assistance. Thank you.
Thank you very much. Yes, Dr. Arthur, you wanted something?
Yes, I think, yeah, for example, while we report that there was increased allocation of finances, it is not as easy as that. It took us a lot of effort to convince, especially the Ministry of Finance, as you know, that government doesn't have enough resources. So they even now have new terms like repurposing, that kind of thing. But so it was not easy, but we used it. That's why we talked about the partnerships, because Accord has an MOU with the Ministry of Finance. And based on that MOU, it gives us a leverage to be able to engage people even separately in strategic meetings, and we are able to convince the powers that be to start to increase financing even in very tight kind of budget. That has not then of course there were also the issues of coordination, especially at the district level, where you find and actually like convincing people that actually this is their role. And it took a lot of conscientization and convincing for some of the district leadership to embrace this. And now, as we talk, of course, it is their thing, and they have seen the value of that. Yeah. So mindset mindset change is not easy because you find that the mindset has been designed to a particular, following a particular direction. And so it takes a lot of tact, a lot of engagement, conscientization, but it pays in the long run. We've seen mindset changing. We've seen people at all levels, national, local level, embrace this activity. Thank you.
So in
Thank
addition,
you. Yes, please.
Martin, in addition, we have just started. We are just in the infancy of introducing digitization in our country. If you look at our supply chain system alone, it's standing as a vertical electronic logistics management information system, mostly in over 6,000 health facilities we have in the country. 2 days ago, we had an assessment conducted by National Medical Store. In addition to the assessment, the Management Sciences for Health conducted 5 years ago. It was reported, and we know that only about less than 23% of health facilities in this country have any form of digital platform which can carry data. Worse still, medical record systems are fragmented. They are not integrated. For example, clinic data does not speak to supply chain data, dispensation does not speak to the laboratory. And we have over 13 electronic systems operating in our health facilities. With that picture in mind, it's not yet possible for us to be able to collect complete, accurate, and integrated data all the time from health facilities. But the process of improving that has started. And then worse still, when you look at the supply of computers in our health facilities, the study from NMS showed that only 23 hospitals had at least, now 23% of the hospitals in this country had at least enough supply of computers, but worse still, just less than 3% were fully digitized and using digital electronic systems. So with that picture, it's not possible right now to have our health facilities accounting and producing real-time data and linking supply chain to patient care fully. But the process has started. The Ministry of Health has advocated for integrated electronic medical record systems. So phase 2, and there's another question from Felix, whether we are ready to quit and leave the health supply chain system to work on its own. No, we are not. We're just at the beginning, at the infancy. So phase 2 will be to increase supply of computers, to increase supply of electricity to all health facilities, to increase supply of internet, to train people, and above all, to ensure that medical workers routinely use electronic digital systems and stop using analog or paper-based systems and be able to report in the National Health Database. So the journey is still on. It's a long way to go, but no, it's not insurmountable. One thing we have proven that it's possible to collect real-time data in supply chain. And we're now supporting the National Drug Authority and the Ministry of Health to put a track and traceability element in all health commodities so we can track them from the warehouses to the health facilities and to the community. So the process has just started. It's not yet the end. Thank you.
Thank you, Dr. Eric. And of course, related to the question that Dr. Lawino answered, one of the core elements in our localization efforts through the digital tools, infrastructure that we are trying to put together is also addressing the sustainability elements of capacity strengthening itself. The SPAS, the supervision, performance assessment, and cognition strategy that Dr. Anne Lawino talked about, is largely a manual approach with a mix of manual and electronic approach. But we have, if you heard what Uganda Health Federation mentioned, we have transitioned, we are in the process basically of transitioning these to a digital assisted SPAS, where individuals and facilities individually can self-assess themselves, and then the system digitally responds to their assessment and qualifies them by giving them the weights of their performance. And if the performance is not good, the system then recommends which of the number of supply chain modules, which is already the next step of capacity strengthening, the individual or the institution should emphasize on. And this becomes a part of a continuous quality improvement exercise that the Ministry of Health has now adopted. So moving forward, as Dr. Eric, the Chief of Partners, just said, we are just at some point, whereas there are things that can be done when we leave, there are things that we still need to help, or any other organization that, like now the partners that we have been working with, if they can continue with this, then sometime in the future, we shall be there. The reason for the partners being, for us transitioning a lot of capabilities to the partners is that they continue doing what we are doing when an organization like ours is not in place locally here in Uganda. Thank you very much. Dennis, any questions that I might have not seen here, I might not be able to see?
Yeah. Thank you, Martin. I'll just run through a few more questions for the panelists. I'll direct one to Dr. Eric. It states that, does that mean Uganda health supply chain is now mature and no more external or international technical assistance, and USAID would fund local organizations directly now that their capacity is developed? I think that's one. The other, unfortunately, Martha is not there, but potentially Anne Lawino can talk to, saying how are national and regional referral hospitals engaged to contribute to the localization of health supply chain systems? I think that's a good one. The one from Felix was already answered. There was a comment to Dr. Arthur saying the improvement from 117 billion to 117 million, 1.8 billion Uganda shillings is still small for districts to implement supply chain activities. I think that's a comment talking to, it's a significant start for the districts to plan, but in terms of an amount for them to implement, it is still quite small. One from Mushimenta, and I think that can go to potentially also Dr. Eric, to any of the speakers. As an upcoming professional in this field, what would be the most important lesson to advise to pass down to get started in the health supply chain in Uganda to ensure good momentum that we have started continues to grow? So I think that those are the questions so far. Thank you, and back to you, Dr. Martin.
Dr. Eric, do you want to make the attempt?
Yeah, sure. No, far from ready. The national supply chain system is just at the beginning. One, I mentioned earlier on, there's lack of integration of the system, logistics and information with the other clinical data at the hospital. As long as we have a vertical supply chain system, that's not good enough. We are just at the infancy of trying to digitize it. We still don't have the capacity to view, track, and trace commodities all the way through the supply chain, from the warehouses to the health facilities, to the patient and to the community. We are building all that process. So, but the beautiful thing is that we have introduced the digital element into the ability to track. So we are in the infancy. We need more work. We still need more support to integrate and be able to view all the data real time in the national data warehouse. So right now it's all hands on deck. And that probably answers the question of the person who asked, what can I do if I'm getting into the field of supply chain? I think one of the things we need to do is think about integrating supply chain medical supplies to other clinical services, lab, clinical, and other related hospital functions, but also think about digitalization and the use of artificial intelligence and electronic systems so that you can be able to track, trace real time the movement, use, and account for commodities within the supply chain. Thank you.
Thank you, Dr. Eric. The question around the growth of financing for the local governments to manage the operations at that level, from 179 to 1.1 still being low, That's true. What is being done or has been done is that through the Ministry of Finance, Planning and Economic Development, and through the national mechanism of budgeting, you will note that if the Ugandans will note that for the last 3 years, the Ministry of Finance has been sending out as part of its budget circular calls to the local governments or to the ministries, departments, and agencies, certain priorities in the supply chain. These priorities are aimed at ensuring that at all levels, government entities plan for the supply chain elements appropriate to their level of operations. So at the district level, we know they need money for supervision. They need money in future to probably bring in experts locally to be able to support strengthening of their health facilities and many others. And again, this falls into the docket of what Dr. Erica said. We are still at infancy. The advocacy needs to continue, and we all need to put together that ability, capability to advocate, to have to fatigue the government to be able to, reprioritize within the little sources it has to address the key priorities in the health sector. And one of them is this one. Without commodities, none of the health programs will really move an inch from wherever it is at the moment.
This small thing to add that the Ministry of Finance, Planning and Economic Development has institutionalized the budget call circular is actually for us an achievement, and I want to agree with Dr. Eric Rugadian that we are still embryonic. We are actually we have broken the ground. We are at takeoff stage. So now what you need to achieve is the institutionalization. But we have also seen, while that looks small, we've seen incremental growth in terms of the budget. For us, that is not a small thing. It has been growing, but of course, slowly. And it's competing with other pressing needs, including education, human capital, and others. So for me, and then of course, there have been those budget consultation conferences which have also been institutionalized, where we went around the country and we are making these presentations to raise the knowledge and the consciousness of leaders, the district local leaders, to institutionalize budgeting or to prioritize budgeting for the essential medicine. And I think that's not a mean achievement.
Thank you, Dr. Arthur. I think we are grinding towards the end. Maybe in a couple of more minutes, if there are any questions still, Dennis, let us know. We saved quite a bit under the presentations.
Yeah, thank you, Martin. I think the questions are exhausted. There's just one that maybe one of the other panelists, Dr. Kamaradi, could talk to. It's just saying, when do discussions start around localization from local partners to the actual individual Ugandan, for them to be able to own the improvement of their own health supply chain systems? I thought Dr. Kamaradi could talk to initiatives around ownership by the local person in the government, local government structures, so that they are fully owning their supply chain and they are accountable. I think other than that, there's one question that I initially directed around how are the national regional FAROs contributing to the localization agenda.
Yeah.
But the rest have been answered. Thank you.
Dennis, why don't you make an attempt to the one of the regional FARO hospitals as we...
All right. Thank you, Martin, for the opportunity to respond to that. So I think, as Dr. Ann earlier on said, the regional referral hospitals have largely been integrated into the localization or local strengthening agenda through particularly one, the direct funding from the US government to the regional referral hospitals. All of you are aware that the regional referral hospitals are centers of excellence in various aspects. And for that matter, they provide regional support to its catchment area. Each of them have about close to 13 to over 20 districts for which they provide support as a catchment area. So through, of course, a very rigorous process, majority of those regional referral hospitals have been supported directly by USAID and by the CDC to actually get funds, and using the high-level staff and specialists that they do have, they've been providing ART treatment and care as well as other services to the region. Through the process, of course, their systems in terms of procurement, accountability, have also been enhanced in preparation for them directly implementing resources towards health broadly, but also supply chain interventions. The second very important aspect of how regional referrals are being involved is also actually through their function of hub and spoke, which means as a center, they are reaching out to the catchment for supply chain, the regional technical working groups that have been instituted in all 16, 18 regional referrals and the 6 national referral hospitals. They are, so to speak, functional. And what is happening is that the government of Uganda staff within the regional referral hospitals are coordinating implementing partners, meaning that the implementing partners are providing direct TA to them to actually continue the good work that partners provide going forward. So I think those are initiatives that are happening, but I think by and large, the success of those initiatives has been very good leadership from most of the referral hospitals that have seen supply chain as an enabler and a cross-cutting factor in all their service delivery initiatives, because without a product, there is no program, so to speak, whether it's prevention or treatment, all those end up with the products that are required to be able to implement. So Martin, pause and stop at that.
Yes, thank you very much. And I would quickly add that what we have been doing and continuing through that technical working group arrangement is to position the regional referral indigenous experts to be prepared to support the districts. Just to remind ourselves that in collaboration with the Ministry of Health and Public Service, the public service did provide for new positions for at least a senior official at the level of a senior pharmacist to take care of pharmaceutical systems as well as the health supply chain at district level. What is now left is to get those. Some districts have already recruited, the majority are still moving on. So having these new positions filled, the sole responsibility of their capacity building, strengthening, will be really the regional referral hospitals through that arrangement. And maybe what Dennis did not mention is that the technical working groups in the region, the supply chain technical working groups, indeed incorporate DHOs of some of the districts as members of the technical working group. And so what happens at the technical working group level cascades not only to the implementing partners who are supporting at the last mile, but also to the technical leadership, the health technical leadership at the district level. We hope this arrangement will then create the environment for the entire country eventually to move forward as part of the change process to position the supply chain as a major driver in health success, in the improvement of quality of care and the improvement on to response to epidemics, in improvements to many other healthcare related interventions. So thank you very much, colleagues, wherever you are, for participating in this. It has been a wonderful occasion to share with you. It has been a wonderful occasion to get your thoughts through the questions and comments that you've shared. And it has been a wonderful occasion to for us as the MSH to hear from our colleagues with whom we have been in this journey, and to really position them and ourselves to better support the people of this country, and particularly the health system. I want to wish you a very good day, good night, and good evening, wherever you are. God bless you.